Hi, I'm Dr. Chris Lewis. I'm one of the chief educators here at Doctors in Training. How are you feeling today? You look a little agitated. Is your heart racing? Is your pulse pounding? Is sweat pouring off you like a faucet? Are you going to go Hulk on me right now? Well, calm down! You might just want to pay attention to our pharmacology lecture today. It's on adrenergic antagonists. Now, I'm not going to completely review the entire autonomic nervous system for you today. That would just take too long. But it is important that we review our adrenergic receptors. So let's go over a quick overview of these receptors. So adrenergic receptors fall into two major categories, alpha and beta receptors. Now, adrenergically innervated organs and tissues tend to have a predominance of one type of receptor. For example, tissues such as vasculature and skeletal muscle have alpha-1 and beta-2 receptors, but the beta-2 receptors tend to predominate. Other tissues may have one type of receptor exclusively, so practically no significant numbers of other types of adrenergic receptors at all. So an example of this would be the heart. It contains mainly just beta-1 receptors and nothing else. Now these receptors are grouped also according to the response to three major neurotransmitters. So epinephrine, norepinephrine, and isoproterenol, which is a synthetic. Now let's talk about the alpha receptors. Now, the alpha receptors have a strong response to epinephrine and norepinephrine, and they're going to have a weaker response to isoproterenol. Now, the alpha receptors are further broken down into different types. So the first one we're going to talk about is alpha-1 receptors. Now, they're located on postsynaptic membranes of the effector organs. Now, this is a bit of a long mechanism here, but alpha-1 adrenergic receptors are members of the G protein coupled receptor superfamily. So upon activation of a G protein, it activates phospholipase C, or we also call this PLC. Now, the PLC will cleave phosphatidylinositol 4,5-bisphosphate. That's a long one. We also call it PIP2 or PIP2. Now, this will in turn cause an increase in inositol triphosphate, and we also refer to this as IP3. It also will increase diacylglycerol, or DAG. Now, the IP3 will interact with calcium channels of the endoplasmic and sarcoplasmic reticulum, and this will increase the intracellular calcium level. Now, this will be sort of the trigger for all the effects of the receptor activation. So the specific actions of the alpha-1 receptor will mainly involve smooth muscle contraction. So remember that, smooth muscle contraction. And this occurs mainly in the peripheral vasculature. So you'll get vasoconstriction, increased peripheral resistance. So this will subsequently lead to increased blood pressure. You also get mydriasis, so dilated pupils. You'll get increased closure of the internal sphincter of the bladder. And then also, which comes to be very important later on in our lecture, increased smooth muscle tone of the prostate gland. Next, let's switch gears over to the alpha-2 receptors. Now, these are located on presynaptic nerve endings and on other cells like the beta cell of the pancreas. So previously, the alpha-1 were on the postsynaptic effector organs. Now, these are on the presynaptic nerve endings. So when a sympathetic adrenergic nerve is stimulated, norepinephrine is released and then can circle back on itself onto the nerve and stimulate an alpha-2 receptor on that nerve ending. Now, the stimulation of the alpha-2 receptor causes a feedback inhibition of the ongoing release of norepinephrine from the stimulated adrenergic neuron. Now, this inhibitory action will decrease further output from that neuron. It serves as a local modulating mechanism for reducing the sympathetic output. Now, activation of the alpha-2 receptor on the mechanism side of things will decrease a production of cyclic AMP, and this will subsequently inhibit the release of the norepinephrine. So the major action, so we just talked about it inhibits norepinephrine, but it can also inhibit acetylcholine release. It can also inhibit insulin release. Next, let's move on to the beta receptor. So we just finished with alpha-1, alpha-2, now we're switching over to beta. So beta, conversely to the alpha receptors, has a strong response to isoproterenol. It has less sensitivity to epinephrine and norepinephrine. Notice that's different from the alpha receptors. Now, all the beta receptors will activate adenylyl cyclase, and this will result in an increase in intracellular cyclic AMP. Now, there are several different types of beta receptors. Now, we're going to talk about beta 1 and beta 2 receptors. They're the most clinically significant of the beta receptors. So, beta 1. So, its major actions are on the heart. So, you'll get tachycardia, increased lipolysis, increased myocardial contractility, and increased release of renin. So, these are when the beta 1 receptors are activated or stimulated, you'll get these responses. Now, for beta 2, so this is different. So its major actions are vasodilation. You'll get slightly decreased peripheral resistance. Very importantly, you get bronchodilation when you stimulate a beta 2 receptor. You'll get increased muscle and liver glycogenolysis. You'll get increased release of glucagon, and you'll get relaxed uterine smooth muscle. So we've just talked about when you stimulate these major receptors. Now, this lecture mainly deals with medications that block all of these messages in receptor activation. So let's first start with alpha-adrenergic blocking agents. So we're blocking these alpha receptors. So in general, sympathetic activation of the alpha-adrenergic receptors is largely responsible for peripheral vascular resistance and thus blood pressure. So these really help clamp down the tone in your extremities. So by blocking alpha-adrenergic receptors, these agents can profoundly decrease blood pressure. Now, the lower blood pressure can then result in a reflex tachycardia. So this is very important because the beta receptors, which we talked about before, remember the beta 1 receptors, the heart receptors, they're not being affected. So you're still going to get activation of those beta 1 receptors, and you'll still get increase in your heart rate, increase in your contractility, increase in your cardiac output, and you can maintain some blood pressure as a result of that. So first, let's talk specifically about phenoxybenzamine. Now, this is a non-selective blocker of both alpha-1 and alpha-2 receptors. Now, it blocks irreversibly. So if you take this medication, you will block your alpha receptors, and they won't be useful again until you grow new receptors. Now, it can sometimes take upwards of 24 hours. So the duration of this medication is somewhere between 14 and 48 hours. Now, it causes little effect on blood pressure in normal supine patients. So you're laying down, you're not doing anything, this medication will not affect you severely. Now, it will reduce your blood pressure during times of elevated sympathetic tone. So an example of that is when you stand up. So you stand up, your sympathetic tone clamps down to maintain your blood pressure, but on phenoxybenzamine, you're not going to be able to because your alpha receptors have been blocked. Other situations where that might be important is during reduced blood volume. So if you have reduced blood volume, you won't be able to clamp down your tone as well as you'd like to with a medication on board. So the next part is, well, what are we going to do for these medications? So you're not going to use them for blood pressure. And the reason for that is that by blocking the alpha-2 receptors, you get elevated levels of norepinephrine. So remember when we talked about what alpha-2 receptors do? They're the negative feedback for norepinephrine. So they're on the presynaptic nerve cells. So by blocking those alpha-2, you can't negatively inhibit your norepinephrine release. So it's going to stimulate your beta receptors because you're going to have increased levels of norepinephrine. So the norepinephrine's floating around, it stimulates the beta receptors, and then you're going to get increased cardiac output, increased blood pressure. So even though you're blocking your alpha, you're actually stimulating your beta with this medication. So when do you use this medication? Well, you're going to use it for pheochromocytoma. Now, what is pheochromocytoma? So it's a tumor of the adrenal medulla or of the sympathetic ganglion cells. And it'll secrete excessive amounts of epinephrine and norepinephrine. Now, the clinical signs of pheo are tachycardia, palpitations, anxiety, weight loss. That's important. And remember this, you're never going to see a fat pheo. So people with pheochromocytoma are usually very thin. You're going to see diaphoresis, and you're also going to get elevated blood pressure. Now, if you have a patient who's thin and has very high blood pressure, and you have them on several medications and it doesn't seem to be working very well, pheo needs to come to mind, and you need to check and rule that diagnosis out. You can also have headaches. You can also have unpleasant skin sensations. So how do you diagnose it? Well, it's made by measuring serum catecholamines, or norepinephrine or epinephrine, in either a 24-hour urine collection or in the serum. And then you're also going to want to do a CT scan or an MRI to help localize the tumor. And again, it's usually in the adrenal gland. So how do you treat a PHEO? Well, the number one is cut it out. You want to resect any pheochromocytomas that you can find. Now, one problem is that you can have a release of stored catecholamines from a PHEO, which can result in some really impressive hypertensive crises. And this can be as a result of physical pressure or a chemical stimulation or just spontaneously. So when you go to resect these PHEOs, you can have a lot of problems with releasing too many catecholamines and causing a hypertensive crisis. So that's where phenoxybenzamine comes in. So this is used prior to surgery to help prevent a hypertensive crisis during the actual resection. So it can be used also occasionally for chronic management for inoperable tumors. So if you can't get at the tumor, then you can use this long-term to help prevent long-term elevations of that catecholamine. Adverse reactions, so you can get postural hypotension, so you stand up and you lose your blood pressure, so that's a common problem. Nasal stuffiness, nausea, vomiting. The alpha receptors are very important for ejaculation, so you can inhibit ejaculation by blocking the alpha receptors. You can get a reflex tachycardia, and it's contraindicated with patients with decreased coronary perfusion. Next, let's move on to a similar medication called phentolamine. Now, it competitively blocks alpha-1 and alpha-2, different from our previous medication that was irreversibly blocking the alpha-1 and the alpha-2. Now, the duration is much shorter. It's about 4 hours. It has similar effects as the phenoxybenzamine. You will get postural hypotension, reflex tachycardia, and it's used for short-term management of PHEO, probably mostly just prior to surgery. Now, it is a little bit different because it can rarely be used to treat impotence. You can inject this directly intracavernosally to produce a vasodilation of the penile arteries. Next, we're going to switch gears to a different disease state. We're going to talk about benign prostatic hyperplasia. Now, I want to talk about this because our next group of medications are used very commonly for this problem. So we also call this BPH. Now, it's a very, very common problem. So men older than 80 years of age, about 80% of them are going to have some level of prostatic hyperplasia. Now, many men are asymptomatic, or they might have just very mild symptoms, but some can have very severe symptoms. And what do they include? Well, you're going to have increased urinary frequency, nocturia, or urinating in the middle of the night too many times, hesitancy, so they have difficulty initiating their stream. They can have urgency, and they can have a weak urinary stream. Now, there's two major mechanisms by which these urinary symptoms can come about from the enlarged prostate. So you can get a dynamic component, and that's related to the tension of the prostatic smooth muscle in the prostate capsule, and also in the bladder neck. Now, there's also a fixed component, and this is related to the bulk of the enlarged prostate. So it's just a large object impinging on the urethral area. So alpha-1 receptors are abundant in the prostate and in the base of the bladder. Alpha-1 receptor blockers are very often used, and another medication that we won't talk about today, classification are called 5-alpha reductase inhibitors, and they're used sometimes together with the alpha-1 receptor blockers to help decrease the size of the prostate and to help symptoms as well. Next, let's talk about the medications that will help BPH, or benign prostatic hyperplasia. So these are the competitive selective alpha-1 blockers. So they include prazosin, terazosin, doxazosin, alfuzosin, and tamsulosin. Now, they relax both arterial and venous vascular smooth muscle. Now, they also relax the smooth muscle in the prostate, which we just talked about. There's lots of alpha receptors in the prostate smooth muscle and also in the bladder neck. Now, you get less tachycardia because there's no alpha-2 blockage. So remember, what did alpha-2 do? It negatively inhibited norepinephrine release. So without that norepinephrine running around, it's going to have less effect on the beta receptors, or the beta-1 receptors. So clinical uses, hypertension and BPH. So those are the two major things you're going to use these classifications of medicines for. So doxazosin has a longer half-life It's about 22 hours long, and that's the longest half-life out of these medications. Tamsulosin is interesting. It has a higher affinity for some subtypes of alpha-1. So alpha-1A and alpha-1D subtypes are what it primarily affects. Now these subtypes tend to be more specific for prostate smooth muscle. So tamsulosin has very little effect on blood pressure, but it has great effect to help with BPH symptoms. Now there are some adverse effects: dizziness, fatigue, nasal congestion, which we mentioned before with our other alpha blockers. Now there's an interesting first dose effect that can be with these medications with orthostatic hypotension. So the very first dose of some of these alpha blockers will cause significant orthostatic hypotension. So one way to help counteract that is by giving either a third or even a quarter of the dose for the very first dose. And we also recommend that we give these medications at bedtime so they can sleep off some of that beginning orthostatic hypotension. But it tends to go away and patients feel better after subsequent doses. It can also inhibit ejaculation. Remember how we talked about how that can be a major problem. Our next medication is yohimbine. Now this is a selective alpha-2 blocker. Now it's a component of the bark of the yohimbe tree. Now this is used to treat orthostatic hypotension because it promotes norepinephrine release. So back to what our alpha-2 does. Well, alpha-2 inhibits norepinephrine. So if you're going to block alpha-2, you're blocking your inhibition. So that norepinephrine is going to float through the serum and it's going to affect your beta-1 receptors. It's going to increase heart rate, increase contractility, increase cardiac output, and increase your blood pressure. Now, it was once widely used to help erectile dysfunction, but it's not used quite as often for that now. Now, also, it can reverse the antihypertensive effects of clonidine. So what's clonidine? Well, clonidine is an alpha-2 agonist. So basically, we're just negating an agonist here.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Welcome back to Who Wants to Be a Gunner? Where the strong shine and the weak are humiliated. Our contestant, Michael here, has already put himself $200 on the board. So, Michael, since you came back, I assume you want to risk everything and try for more.
That's right, Regis. You know, I think I just need to step up my game.
It's your funeral. Okay, let's play Who Wants to Be a Gunner? Your next question. Alpha adrenergic antagonists, such as tamsulosin, are used to treat benign prostatic hypertrophy, but might cause which of the following side effects? A. Hair loss. B. Hypotension. C. Diabetes. Or D. Erectile dysfunction. How'd you do in pharmacology, Michael?
Well, I had a little bit of trouble with pharmacodynamics, but, you know.
But you're not exactly AOA material, huh, Michael? What is the side effect of tamsulosin?
Hypotension. Final answer.
I don't believe it, folks. Hypotension is correct for $300. How he keeps doing this, folks, I do not know. Stay tuned to see if Michael continues this streak as we play Who Wants to Be a Gunner?
Hi, I'm Dr. Mike McInnes. Let's go through the answers to quick review number 1 in your study guide. First question, what are the effects of alpha-1 receptor blockade? So it's really important that you know the differences between the alpha-1 and alpha-2 and beta-1 and beta-2 receptors and what those receptors do, what agonism of those receptors does, and what antagonism of those receptors does. So here we're talking about alpha-1 receptor blockade. So what does an alpha-1 antagonist do? Well, basically it's going to do the opposite of what an alpha-1 stimulator, an alpha-1 agonist does. So alpha-1 blockers will cause decrease in peripheral resistance, which is going to decrease your blood pressure. They'll also lead to meiosis, or constriction of the pupils. They will lead to decreased closure of the internal sphincter of the bladder, and they will also cause decreased smooth muscle tone of the prostate gland. Next question. A 72-year-old male presents after an episode of syncope. The patient reports that he was recently started on a medication for his prostate. What likely caused his syncopal episode? Well, this patient is probably having the first dose effect of an alpha blocker. If you're going to restart this medication, you should start with a smaller dose, maybe a third or a quarter dose for that first dose, because they can have first dose hypotension and cause syncope. But if you start with a smaller dose, they may be able to tolerate it. Next question. The above 72-year-old patient was originally started on prazosin, there's that alpha blocker, for his benign prostatic hyperplasia. What other alpha blocker may be appropriate that might not affect his blood pressure as much? So he had trouble with prazosin, but there are other alpha blockers that you might try. One of these is tamsulosin. Remember, tamsulosin is an alpha-1 blocker that doesn't cause as much hypotension, so it may be appropriate for patients who have normal blood pressure or even low blood pressure but need something for their BPH. Next question. Why would this patient's ophthalmologist be interested in knowing how you're treating his BPH? It may not be really obvious that what you're doing to his prostate has anything to do with his eyes. BPH is primarily a disease of middle-aged and older men. And there are lots of diseases that are more prevalent in this older population. One of the most common is cataracts. The only treatment for cataracts is surgery, and it's pretty low-risk surgery. You just take out the cataract and you put in an artificial lens. But patients who have taken an alpha-1 blocker, especially tamsulosin, are predisposed to a condition called intraoperative floppy iris syndrome. Basically, this means that the iris is flaccid, and it prolapses, and it may even constrict intraoperatively. So patients that have ever been on an alpha blocker may have a more complicated cataract surgery or a more complicated post-op course. This drug effect can be long-lasting, so it usually isn't recommended to stop the drug or switch to something else preoperatively. But there are some things that the ophthalmologist can do during surgery to reduce the risk of problems. Now, as a primary care provider, I like to discuss this carefully with patients before I even start an alpha blocker. Have they already had cataract surgery? Then there's no problem. Have they seen an ophthalmologist who's been talking to them about cataracts and saying, well, you're going to need surgery eventually, but it's not there yet? They may want to talk to their ophthalmologist about when that surgery might take place before they start the alpha blocker. If they're going to have cataract surgery in 6 months, I would say either push the cataract surgery up and get it over with, or delay the alpha blocker until after the cataract surgery. If the patient is informed of the potential risk, the patient may choose to try a different class of medication for the BPH altogether. Next, what other class of medications are used for BPH? Well, these include the 5-alpha reductase inhibitors. 5-alpha reductase is the enzyme that converts testosterone to dihydrotestosterone, which is the more potent form of testosterone. So if you block 5-alpha reductase, you block the effects of testosterone. And over time, you can shrink the prostate and improve symptoms. Now, 5-alpha reductase inhibitors include drugs like finasteride and dutasteride, and they're often combined with the alpha blockers to further improve BPH symptoms. These drugs are further discussed in the solid pharmacology lecture on androgens and anti-androgens. Next question. A 70-year-old patient with no significant medical problems presents with classic symptoms of BPH. So these symptoms include frequency, urgency, hesitancy, nocturia, weak stream, incomplete emptying of the bladder. Before starting this patient on medication to treat his symptoms, what other serious problem should you rule out? So the serious problem you need to think about is prostate cancer. Prostate cancer can have similar and identical symptoms to BPH. So clinically they may present exactly the same way. So don't just assume this patient has BPH. You need to perform a digital rectal exam. You're going to feel the prostate, see if it's diffusely enlarged, which might suggest BPH, or feel if it's hard or maybe nodular, which might suggest prostate cancer. And you're also going to want to do a blood test called the PSA, or prostate-specific antigen, which can be a marker for prostate cancer. Next question. Explain how non-selective alpha blockers cause a reflex tachycardia. So alpha-2 receptors are on the presynaptic nerve terminals, and they inhibit further release of norepinephrine. So if you block alpha-2 receptors, it's going to lead to less inhibition of norepinephrine release. So you're going to have more norepinephrine. And when you have more norepinephrine, that's going to stimulate the beta-1 receptors in the heart and lead to tachycardia. Next, Explain the mechanism of action of clonidine. So clonidine is an alpha-2 receptor agonist. So stimulation of alpha-2 leads to an overall decrease in norepinephrine release, and less norepinephrine results in a decrease in blood pressure. And that's the end of the quick review. Now let's go back to Dr. Lewis.
So let's move on now to the beta-adrenergic blocking agents. So let's do a review of what a normal beta-1 and beta-2 do. So beta-1, heart, tachycardia, increase lipolysis, increase myocardial contractility, increase release of renin. Beta-2, vasodilation, slightly decrease in peripheral resistance, bronchodilation, increase muscle and liver glycogenolysis, increase release of glucagon, and relaxation of uterine smooth muscle. So that's our review. Now, all the beta blockers will inhibit competitively. There's no irreversible blockers that we use clinically. Now, some have higher affinity for beta-1 than for beta-2, but none are absolutely selective. And that selectivity is dose related. So if something is only a beta-1, it'll still have a little bit of beta-2, but the higher dosage you go on that medication, you lose that selectivity. So it's not just beta-1 anymore, it's beta-1 and beta-2. Now, all the beta blockers lower blood pressure, but there's not very much postural hypotension because the alpha adrenergic receptors are still functional. And now what do the alphas mostly do? So the alphas maintain your peripheral resistance. So you'll still have that normal sympathetic tone and you'll still have that maintained peripheral vasculature. So in general, you're going to treat a lot of things with beta blockers: angina, cardiac arrhythmias, myocardial infarctions, congestive heart failure, hyperthyroidism, and glaucoma. Let's talk about specific medication. So the prototype beta blocker, the one that we came up with first, is propranolol. Now, it is a non-selective beta blocker, so we're going to talk about this medication to sort of represent all of the non-selective beta blockers. Now, it blocks beta-1 and beta-2, so it's non-selective. Now, let's talk about its actions on the body. First, we'll talk about cardiovascular. So you'll get negative chronotropic and inotropic effects. So you'll get decreased speed of the heart, decreased contractility or force of the heart. You'll get decreases in sinoatrial and atrioventricular activity, and this can lead to bradycardia, and this can limit the dosage of this drug that you can use. You get decreased cardiac output and oxygen consumption. Now, this is very useful in the treatment of angina. We'll talk about that here in a minute too. It can be used for supraventricular cardiac arrhythmias, and it can suppress the release of renin. And we're not really sure about this mechanism, but it's still very helpful for blood pressure control. Next, how does it affect peripheral vasoconstriction? So it blocks beta-2 mediated vasodilation. So remember our beta-2, when you stimulate those, you get vasodilation. So now you're going to get some vasoconstriction. So this can occur also as a result from the decreased cardiac output and the decreased blood pressure as well. It's also good to help decrease orthostatic hypotension. So that increased vasoconstriction can help you from having problems with dizziness and passing out. Now, one drawback to that vasoconstriction is that you can have coldness of the extremity. So you will have patients who, after taking their beta blocker, will say, gosh, you know, my hands are cold all the time. Next, let's see how it affects the eye. So it actually reduces intraocular pressure, and this is especially important in patients with glaucoma. Now, the mechanism is due to a decrease in aqueous humor production. Next, and this is very important, bronchoconstriction. So beta-2 blockage can lead to contraction of smooth muscle in the bronchioles. Now remember, as we said before, it all goes back to our receptors. Beta-2 caused bronchodilation. So without that bronchodilation, you're getting bronchoconstriction now. The non-selective beta blockers should not be used in asthmatics. And most of the time, you shouldn't use them in patients with chronic obstructive pulmonary disease either, or COPD. Next, it'll affect sodium retention. So decreased blood pressure will lead to decreased renal perfusion, and this generally leads to more sodium retention and increased plasma volume. Now, to help counteract this, because basically your kidneys are realizing that you have decreased blood flow, and it's trying to correct that. So it'll counteract your beta blocker by increasing the volume and then thus increasing your blood pressure. So to help counteract that, we often combine beta blockers with diuretics to help let some of that extra plasma volume go. The next affecting system is the metabolic and endocrine system. So you get decreased lipolysis, you get decreased glycogenolysis, you get decreased glucagon secretion. How is this important? These all result in potential fasting hypoglycemia. Now this is extra concerning because these non-selective beta blockers can mask the typical signs and symptoms of hypoglycemia, which are diaphoresis, shakiness, tachycardia. So one, it can cause a decrease in the sugar in your body, and then you can't feel that it's low. So that can be a big problem, and you have to be very careful with patients with diabetes. So we know how these medicines affect the body systems. Let's talk about their therapeutic uses. So number one is hypertension. So due to decreased cardiac output and the inhibition of the renin release, you get lower blood pressures. You use it in glaucoma, and it's due to the decreased aqueous humor production. We haven't talked about this yet. It can be helpful for prophylaxis for migraine headaches. So this might be due to the blockade of the catecholamine-induced vasodilation in the brain that you see with migraines. Hyperthyroidism. So you can block the elevated sympathetic stimulation associated with hyperthyroidism, and it's very, very useful in thyroid storm. So thyroid storm is a life-threatening situation that can be very impressive. Patients can have very high fevers up to 106. They can have heart rates up to 140. They can get fatal cardiac arrhythmia. So beta blockers are the first thing we use to help counteract that increased sympathetic tone. Angina pectoris, so chest pain. So these beta blockers will decrease oxygen demand of the heart, and they can be used for chronic management and for acute treatment. And for myocardial infarctions, they can be cardioprotective. So you give patients beta blockers, and it helps protect the heart. And if it can be used prophylactically on patients who have had an MI, and by taking the beta blocker, you'll have less likely to have a second MI. Now, you can also administer beta blockers immediately following a myocardial infarction, and this will help reduce the infarct size and will also hasten recovery. And there's also an added benefit in giving a beta blocker after an MI because it can decrease the sudden arrhythmic death after a myocardial infarction. Let's talk a little bit about the adverse effects. So number one, we talked about this before, bronchoconstriction. You never want to use these non-selective beta blockers in an asthmatic, and you have to be very, very cautious in someone with COPD. They have to have a really good reason to be on a non-selective beta blocker. Bradycardia, and this is probably the most common side effect. So you give these medications and you're going to decrease their heart rate. You have to be very careful, especially in the elderly, because they're going to be more prone to passing out, having orthostatic hypotension, falling, and then hurting themselves. You have to be worried about arrhythmia. So you don't want to go through an abrupt cessation of beta blockers because this can cause an arrhythmia. You want to titrate down these medications over the span of about a week or two. Sexual impairment. So men will complain of erectile dysfunction. Now, the cause is a bit unknown. Most male sexual function is controlled through alpha receptors, but this is still a pretty common complaint of a lot of men taking the beta blockers. Fatigue is a big one. We're decreasing our overall sympathetic tone. Therefore, patients will feel a little tired. Hypoglycemia, which we talked about before, so you're decreasing your glycogenolysis and you're decreasing glucagon secretion, and this can, again, result in fasting hypoglycemia, and you have to be extra careful in your diabetics, especially who are on hypoglycemic medicine. And again, you're going to be blocking the effects of that hypoglycemia, so diabetic patients won't know that they're hypoglycemic. There are a few drug interactions you need to be on the look for. There are some medicines that will potentiate or increase the effect of propranolol, and these include cimetidine, fluoxetine, paroxetine, ritonavir. And then there's some that actually decrease the effect of propranolol, and this includes barbiturates, phenytoin, and rifampin. Now, there's some beta blockers that are used topically, and they're used mostly for our glaucoma patients. So these are non-selective beta blockers, and they include timolol, levobunolol, and betaxolol. And again, they're used topically for glaucoma, and they decrease the production of aqueous humor. Next, we're going to move on to selective beta-1 antagonists. So sometimes these are referred to as cardioselective, meaning they're beta blockers that really only affect the heart. And these are very widely used and very popular. So the selective beta 1 antagonists were developed to attempt to avoid the bronchoconstriction problem of the non-selective beta blockers. And the selectivity is again lost at higher dosages. So if you push a dose far enough, you're going to start getting that beta 2 blockage as well. So let's talk about its actions. It's going to be pretty similar to the non-selective beta blockers. So cardiovascular, lower blood pressure, and increase exercise tolerance for your anginal patients. Bronchoconstriction is much less of a problem, but these drugs are still not absolutely selective, and you want to be careful with your asthmatic patients and probably don't want to use these medications unless it's absolutely necessary. Metabolism, so there's little effect on glycogenolysis and glucagon secretion, so you can use these in diabetics a little bit more easily. Peripheral resistance, so there's little effect on peripheral resistance with no beta 2 blockade. So your beta 2 was responsible for some mild vasodilation, so you're not blocking that. So you're going to have decreased coldness of your extremities. Specifically, esmolol is a very short-acting beta blocker. It has a short half-life. It's sometimes given IV during surgery if it's needed during surgery. Nebivolol is the most highly selective beta 1 blocker, and it can also elicit vasodilation, which may be due to stimulation of the endothelial nitric oxide pathway. Other selective beta 1 antagonists will include atenolol and metoprolol, and we've already talked about esmolol and nebivolol. So our next group of medications are the beta antagonists with partial agonist activity. So this includes acebutolol and pindolol. So they're similar to the other medications with beta blocking, but they also will weakly stimulate both beta 1 and beta 2. But this is much less than the surrounding catecholamine. So they'll bind and block beta 1 and beta 2, but they're still stimulating those receptors a little bit. So you get less effect on cardiac output and the rate. So you'll get fewer problems with bradycardia. And it can be used in hypertensive patients with mild to moderate bradycardia problems. It has a less of effect on metabolism as well, and it can be given mostly pretty safely in diabetics. Next, let's talk about labetalol and carvedilol. Now, these are considered alpha and beta antagonists. So they have both beta blockade and alpha 1 blockade. So they're different from the other beta blockers because you get peripheral vasodilation instead of peripheral vasoconstriction. So the alpha 1 is mainly concerned with maintaining your peripheral tone. So if you're decreasing that peripheral vascular resistance by blocking alpha 1, you're going to get overall a vasodilation. So this is very useful in treating patients with hypertension for whom increased vascular resistance is undesirable. So examples are, say, in the elderly. They have already some probably peripheral vascular disease, and you don't want to make that potentially worse. Black patients tend to have more problems with peripheral vascular disease as well. Labetalol can also be used to treat pregnancy-induced hypertension. Labetalol is also used in an IV form to treat hypertensive emergencies. Adverse effects, similar to the other beta blockers, orthostatic hypotension and dizziness. So finally, let's talk about some drugs that don't fit into these categories very well. Now, these are drugs that affect neurotransmitter release or uptake. They don't actually act on the adrenal receptors themselves. They act on norepinephrine more than anything. Now, these medications are very rarely used, but still you should probably know something about them. The first one is reserpine. Now, it's a plant alkaloid, and it blocks the magnesium ATP-dependent transport of biogenic amines. So what are biogenic amines? So that includes norepinephrine. It also includes dopamine and serotonin. Now, it impedes this transport from the cytoplasm into the storage vesicles in the adrenergic nerve. So you can't get the norepinephrine into its storage space. Now, overall, you decrease sympathetic tone. It has a very slow onset and has a long duration, so you just very slowly deplete your norepinephrine stores. Guanethidine will inhibit the release of stored norepinephrine, and it will actually displace norepinephrine from storage vesicles. So when you first give this medication, you actually might get an increase in blood pressure, an increase in sympathetic tone. but eventually you get a gradual depletion of your norepinephrine, and you'll get a very similar response to the reserpine. And then finally, we should probably mention cocaine. Now, cocaine will inhibit norepinephrine uptake. In and of itself, cocaine is an adrenergic agonist, so it sort of balances itself out, and we don't use that clinically very often either. So I hope you enjoyed our lecture today on adrenergic antagonists. I hope you were able to hold back the Hulk today and calm down your sympathetic tone, and I'll see you next time.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
When we left, Michael had just gotten himself up to the $300 mark. Not bad. I guess you respond well to pressure. Let's keep it going. Next question for $400. Which of the following drugs is both an alpha antagonist and a beta antagonist? A. Carvedilol. B. Propranolol. C. Pyrazosine. Or D. Phentolamine.
Okay. Wow. I think I know this one.
Wonders never cease.
Yeah, it's definitely,
Hesitation kills. You must know instinctively and act immediately. Lives may be at stake.
it's carvedilol. Final answer.
Carvedilol is correct for $400. No more lucky guesses, smart guy. The next question is for $500. Which of the following drugs is a non-selective beta antagonist? A. Atenolol. B. Nadolol. C. Metoprolol. Or D. Esmolol. Do you need me to read the question again?
No, I can hear you just fine, thanks.
No need to get snappy with me, mister. It's not my fault you have a brain the size of a pea.
I think it might be Nadolol.
You think?
Yes, Nadolol. Final answer.
Nadolol is correct for $500! Wait a man up. Unfortunately, we are out of time. Tune in next time while we play Who Wants to Be a Gunner?
Okay, let's go through quick review number 2. First question, what alpha-beta blocker can be used IV in hypertensive emergencies? Well, this is labetalol. Next, by what mechanism do beta blockers improve glaucoma? Well, beta blockers will decrease production of aqueous humor. Next, a 45-year-old female with well-controlled diabetes has a blood pressure of 138/88. She's already taking lisinopril, hydrochlorothiazide, and amlodipine. What should be the blood pressure goal for this patient? Well, I don't want you to be fooled by the fact that her blood pressure is less than 140/90 and think, well, that's good enough. It usually isn't, especially for patients with any kind of comorbidities or cardiovascular risk factors. And diabetes is definitely a big risk factor for cardiovascular disease. So the blood pressure goal for a diabetic is less than 130/80. So this patient is already a little bit above that. So we need to adjust something. We need to do something for her. She's already on an ACE inhibitor, lisinopril. She's already on a thiazide diuretic, hydrochlorothiazide. She's already on a calcium channel blocker, amlodipine. So this is a pretty good regimen, but her blood pressure is still above goal. So since we're talking about beta blockers, what type of beta blocker would you consider using? Well, consider starting a selective beta-1 blocker, such as metoprolol or atenolol. Why? Well, remember, the beta-2 stimulation causes increased glucagon and increased glycogenolysis. Remember, that's part of that fight or flight response. You need a lot of energy, so you get your blood sugar up by stimulating beta-2 receptors. So if you blockade beta-2 receptors with a beta blocker, you're going to cause decreased glucagon and decreased glycogenolysis, and so you might be more predisposed to hypoglycemia. Now, frankly, this isn't a huge problem for most people. But say this is a diabetic who's taking insulin, or she's taking a sulfonylurea, which is going to predispose her to hypoglycemia. And then you add a non-selective beta blocker, well, that's going to further increase her risk of hypoglycemia. So it's certainly okay to use beta blockers in diabetics. But if you do so, you want to do it carefully, and you generally want to use one of the beta-1 cardioselective drugs, if possible. Next, a 65-year-old patient presents with an exacerbation of his congestive heart failure. He's been off of his medications for the past week. Unfortunately, this happens very frequently. Patients stop their medication for whatever reason. They're having side effects, or they're traveling, they forgot their medicine, or they say they can't afford their medicine. And then they end up in the emergency room with a CHF exacerbation or a COPD exacerbation or whatever. So anyway, his medications include furosemide, lisinopril, and metoprolol. Which of these medications should you restart immediately? So you restart furosemide because you definitely need that diuretic in a patient with volume overload, congestive heart failure. And you're going to restart lisinopril, which is your ACE inhibitor. But do not restart a beta blocker during an acute exacerbation of congestive heart failure. Metoprolol and other beta blockers will reduce myocardial contractility because they're blocking the beta-1 receptors in the heart. And so beta blockers are contraindicated in acute CHF. You don't want to reduce myocardial contractility in someone who's got depressed myocardial contractility if you can avoid it. In chronic CHF, beta blockers are good because they reduce long-term hospitalizations, they reduce mortality. In acute congestive heart failure, you don't want to use beta blockers. Next, which alpha-beta blocker can be used in pregnancy? This is labetalol. There are 4 antihypertensive drugs to remember that are safe for use in pregnancy: methyldopa, hydralazine, nifedipine, and other dihydropyridine calcium channel blockers, and labetalol. Next, a patient is having a hypertensive crisis during surgery. Which beta blocker would be the most appropriate in this situation? Well, the most appropriate beta blocker would be esmolol. It has a very short half-life, shorter than all the other beta blockers, and it can be given IV. During surgery, you don't really want to use a drug that's going to stick around a long time that you can't reverse rapidly if you need to. Maybe the blood pressure gets too low after you give the beta blocker and you need to raise it, but oops, you give a drug that has an 8-hour half-life or something. So anesthesiologists like to give drugs that have a rapid onset of action and a short duration of action. So in this situation, you give a little IV push of esmolol, bring that blood pressure down, and as the esmolol wears off, you can give a little more if you need to. So that's the end of the quick review. Now I want you to pause the video, answer the questions on your end of session quiz, and then restart the video and we'll go through those answers.
Well, I'm here now, so you can stop paging me. Why can't my cases ever start on time? What's the holdup? All right, let's get to it. Why do you have to be careful when giving non-selective beta blockers to asthmatics? Beta-2 blockade can cause bronchospasm. And why do you have to be careful when giving beta blockers to diabetics? Beta blockers can interfere with glucagon secretion, which may cause hypoglycemia. Plus, they may mask the symptoms of hypoglycemia. Who's been messing with my lights? There. Nobody touches my lights but me! Nobody!
All right, let's go through the answers to your end of session quiz. First question, what are the effects of alpha-1 receptor stimulation? So alpha-1 receptor stimulation is going to cause vasoconstriction, which will lead to increased peripheral resistance, which will increase the blood pressure. It will also cause mydriasis. The way I can remember mydriasis versus meiosis, mydriasis is a long word, so you think about the pupil being dilated. And remember, with the fight or flight response, you want to get lots of light in so you can see what you're fighting, so you need those pupils dilated. So alpha-1 stimulation causes mydriasis. Alpha-1 stimulation will also cause increased closure of the internal sphincter of the bladder. You don't want to be urinating while you're fighting. It will also cause increased smooth muscle tone of the prostate. Next, what are the effects of alpha-2 receptor stimulation? So alpha-2 stimulation will cause inhibition of norepinephrine release. It will cause inhibition of acetylcholine release. It will also inhibit insulin release. Next, what are the major actions of beta-1 receptor stimulation? So sometimes it's easy to get mixed up on which beta receptors are in the heart and which ones are in the lungs and the airways and the vessels. Just remember, you have one heart but two lungs. So beta-1 acts on the heart, beta-2 acts on the lungs. So here we're talking about beta-1, heart, So this is going to cause tachycardia. It's also going to cause increased myocardial contractility. Also, with beta-1 stimulation, you're going to get increased lipolysis and increased release of renin. Next, what are the major actions of beta-2 receptor stimulation? So beta-2 is for your lungs, your airways. So you're going to get bronchodilation. It will also cause some vasodilation, and you'll have slightly decreased peripheral resistance because of that. Beta-2 stimulation will also increase glycogenolysis and increase the release of glucagon, and it will cause the relaxation of the uterine smooth muscle. Next, what are the therapeutic uses of beta blockers? So beta blockers are used in lots and lots of different diseases. They can be used to treat hypertension, glaucoma, as we've mentioned. They can be used to treat or prevent migraine headaches. They can be used acutely to manage the symptoms of hyperthyroidism. They don't affect the thyroid, but they affect the symptoms of hyperthyroidism. They can be used to treat angina, and they're used in post-myocardial infarction patients because they reduce morbidity and mortality. They can be used to treat tachyarrhythmias because they slow down the heart rate. And they're also used in chronic compensated congestive heart failure. Remember, I said we don't use beta blockers in acute congestive heart failure, but for chronic compensated heart failure, they're a good thing. Next, what class of medication is good for treating hypertension and benign prostatic hyperplasia? These are the selective alpha-1 blockers. Next, what are the major benefits to using a selective beta-1 blocker over a non-selective beta blocker? So remember, the beta-1 blockers are more cardioselective, so they're going to cause less bronchoconstriction, you're going to have less hypoglycemia, and you'll have less peripheral vasoconstriction. Next, choose the best drug for each clinical scenario, and you have your choices there. So the first scenario, 67-year-old male with hypertension and a history of mild bradycardia. This would be acebutolol. Remember, it's a beta blocker with partial beta agonist activity. A 65-year-old male with mild hypertension and BPH. This would be prazosin, one of those alpha blockers, as we said. A 70-year-old African-American man with hypertension and peripheral vascular disease. You might reach for carvedilol. It's in addition to being a beta blocker, it's an alpha blocker. So you have no peripheral vasoconstriction. And then the 24-year-old pregnant female with pregnancy-induced hypertension. Remember, labetalol was the beta blocker that was safe to use in pregnant patients. Next, why must patients with diabetes be cautious with non-selective beta blockers? Remember, non-selective beta blockers can cause fasting hypoglycemia. Beta blockers can also mask the typical symptoms of hypoglycemia like shakiness and tachycardia, which are all sympathetically mediated. This is not just non-selective beta blockers, but any beta blocker can do that. But specifically, the non-selective beta blockers that are blocking beta-2 as well as beta-1 receptors can lead to hypoglycemia, as we mentioned earlier. Next, in which patient should you use caution when starting a beta blocker? Well, several groups of patients. First of all, asthmatics, because beta blockers can cause bronchospasm. You definitely want to avoid non-selective beta blockers in any asthmatic. And if you're using a selective beta blocker such as metoprolol or atenolol, you want to use those with caution because at higher doses they can have some beta-2 activity. You also want to be cautious when starting a beta blocker in a diabetic because the risk of hypoglycemia, as we just discussed. Obviously, in patients with uncontrolled congestive heart failure, remember beta blockers have a negative inotropic effect and may make things worse. So remember, if you have an acute exacerbation of CHF, you don't want to use beta blockers at all. But in someone who has congestive heart failure that's not terribly well controlled, but they're not in an acute exacerbation, you may be able to start a beta blocker, but it's kind of iffy. And then finally, any patient with bradycardia, obviously beta blockers are going to exacerbate bradycardia, so you want to avoid them if you can. So that's the end of the end of session quiz, and that completes the lecture on the adrenergic antagonist. Good luck studying.